Welcome to the essential guide for medical students on orthopedic emergencies. In the emergency ward, time is critical, especially in orthopedics where a delay can mean permanent disability. The phrase time is bone highlights the urgency of prompt action. This video will walk you through 20 key orthopedic cases, their clinical examination, radiology, and treatment protocols. Whether you're preparing for your final year Viva or ward rounds, mastering these cases will boost your confidence and clinical skills. Let's start with the first 5 emergency cases you'll encounter most often. Hall's fracture is a common wrist injury, typically caused by falling on an outstretched hand. Patients present with severe pain, swelling, and a deformed wrist, often described as a dinner fork appearance. During clinical examination, inspect for deformity, palpate for tenderness, and check neurovascular status using a pulse oximeter. Measuring tape helps assess displacement. Radiology reveals a dorsal tilt and radial shift. Treatment involves closed reduction and a Hall's cast, with pain managed by Zerodol P and swelling by Chimeral Forte. Early intervention is crucial to prevent long-term disability. Shoulder dislocation often results from trauma, leading to inability to move the shoulder and a flat deltoid contour. Key examination steps include inspection for shape change, Dugas and Hamilton ruler tests, and axillary nerve assessment with a sterile pin. X-rays confirm the humeral head displacement. Treatment involves reduction techniques like Kocher's or Stimson's, muscle relaxants such as Myospas or Miofre, and immobilization with a sling. Sedation may be needed for pain. Prompt management restores function and prevents nerve injury. Hip fractures, especially in the elderly, often occur after minor trauma due to osteoporosis. Patients can't move or stand on the affected leg, which appears shortened and externally rotated. Examination includes inspection, palpation for groin tenderness, and measuring limb length. X-rays reveal fractures at the femoral neck or trochanter. Immediate care involves skin traction to reduce pain and prevent further displacement, anticoagulants like Lovenox to prevent clots, and pain relief with Perfalgan. Surgery may be required for definitive management. Compartment syndrome is a surgical emergency characterized by severe pain, pallor, pulselessness, paresthesia, and paralysis, the 5 Ps. It often follows tight casts or severe trauma. Clinical diagnosis is key, supported by BP apparatus and pulse oximeter. X-rays may show fractures, but pressure measurement is crucial. Immediate removal of constricting dressings and timely fasciotomy are life and limb-saving. IV fluids help protect the kidneys from toxins released by damaged muscle. Delay can result in permanent loss of function. Open fractures involve bone protruding through the skin, often after road accidents or falls. These injuries are at high risk for infection. Examination includes assessing wound size and contamination. Immediate wound wash with saline, antibiotics like Monosef and Metrogel, and tetanus prophylaxis are essential. Stabilization with external fixators prevents further damage. Early and thorough management is vital to prevent complications like gangrene and sepsis. Well-equipped orthopedic ward is essential for effective emergency care. Key tools include measuring tape for limb length, splints like Kramer wire or Thomas splint for immobilization, crepe bandages and pop rolls for casting, and goniometers for measuring joint movement. Each tool has a specific role in diagnosis and management, ensuring accurate assessment and stabilization of injuries. Familiarity with these instruments is crucial for every medical student in the emergency setting. Supracondylar fractures of the humerus are common in children and can threaten blood supply to the hand. Look for swelling, inability to move the elbow, and check for radial pulse using a pulse oximeter or Doppler. The 3-point relationship of elbow bones is altered. X-rays show fracture displacement and fat pad sign. Treatment includes emergency reduction, K-wire fixation, and close monitoring for Volkmann's ischemia. Antibiotics like Taximo are used to prevent infection.